welcome to today's webinar, Mastering Massachusetts Active Assessments and PDPM Nursing CMGs, presented by QRM. QRM is an in-house rehab management company that works with skilled nursing facilities across the country. We also provide MDS education and training, medical review, compliance assistance, and marketing services. Visit qrmhealth.com to discover more about QRM and its services. My name is Amy, and I will be your moderator for this session. Before we get started, I'd like to go over a few housekeeping items to ensure that we all have a seamless experience throughout the webinar. So first up, this webinar will be recorded, and you will receive an email with a link to the QRM Health website to access the recording and resources within 24 hours of the time right now. And secondly, the handouts are available to you at the link in the chat. So if they're not there yet, Zach will be placing a link in there for you so you can pull those up and follow along. And lastly, throughout the presentation, we do encourage you to ask questions. And you can do so by typing those questions in the Q&A area, which you will find in the Zoom toolbar at the bottom of your screen. We will review those questions received, and we will release a Q&A document in the week following this webinar. I now pass it off to Mark Heider, VP of Reimbursement Strategy and Education for QRM, who will introduce today's speakers.
Thank you very much, Amy, and welcome. We're glad you joined us today. Very happy to be here with you. And I have two people with me that I'm very proud to have presenting this topic. Matt Cameron, our Senior Vice President of Data Analysis and Innovation, and Stacy Grondel, our Director of Clinical Reimbursement. And I want you to know these two have spent numerous hours collecting information, putting this together, talking, collaborating with other healthcare officials and representatives from Massachusetts, making sure they have as solid as understanding as they really can. One of the things I want you to know, though, is there's still information rolling out. There's still kind of, it's not coming to us quickly in some cases. So there may be questions that all of us have that haven't been answered yet. So I want you to be aware of that. But in any case, this is a big change. It's a big paradigm shift for the facilities in Massachusetts. And we understand that. But during this hour, I want you to think about your processes and reassess your processes and say, what works for us and what doesn't. I want you to think about who you have in place that's collecting the information that you're going to need and make sure you have the right people in place. There are times when you're going to look, especially in the future, at will this guide your admissions patterns? And it's a question worth asking yourself. And one of the things that we're always conscientious about and have in other systems, but will be even more critical as you're looking at the new system, is recognizing changes in patient status, long-term resident status quickly, being able to recognize those, document those. The last piece I'm going to mention, because Matt and Stacy have a great program for you today, but the thing you want to keep in mind is how you're tracking payment. So there's a lot here. Now, Matt Cameron has been working for QRM for numerous years and has been a very skilled operator. He's a physical therapist by background. He is a data analysis expert and really does an exceptional job at understanding how things work. And Stacy is one of the best nurses I've worked with. She has a strong background in the MDS world, but as a clinician, she also is very strong as a teacher and trainer. She works with APAC and other groups to train. So I think you're in the best hands possible. I want you to listen closely. And as Amy said, please submit your questions because we will respond to those in a written format. We want you to have all the answers that you can have. And again, thank you for joining us. And Stacy and Matt, I'm going to pass it off to you.
All right, Mark. Well, thank you so much for that introduction. And hey there, everyone out in the Bay State. Zach, if you can start the slides rolling. Yeah. All right, we've got a lot of changes to update you on today. So let's get started with a brief overview of what we're going to cover. So the first item on the agenda is going to be that the current MMQ reimbursement model is being replaced with a new case mix model based off of the PDPM nursing case mix groups. And I'm sure for the most part, that's what everyone's here to learn about. We'll also be covering how that new PDPM reimbursement model will be establishing payment rates and how the payment periods for those rates will be established. And a little bit of a sneak peek ahead at an item that we'll be going over to play a much bigger role in long-term care reimbursement, and that is going to be your sick change assessment, right? So sneak peek ahead, that's going to be a whole new world compared to what we've been seeing in the past. And last, we'll be going over some quick reminders on what we will still need to do for MMQ. It's not quite October yet. Zach, if you can hit the slide. So, as I said, first we've got to talk about our last ride into the sunset with MMQ. But don't get too down. We've got a brand new case mix model coming over the horizon there. So we're going to see a hard transition for our payment rates being based off of the MMQ model on September 30th to then all residents having a new payment rate based off of PDPM starting on 10/1. At first glance, that might seem overwhelming, and well, yeah, maybe it is. But there's going to be a lot of pieces to the new model that I think everyone is going to recognize and start to feel right at home. The PDPM that the Medicaid rates will be based off of is going to be the same PDPM that we've been working with for our Med-A residents for the last 4 years. But with one caveat, it's going to be even easier because you'll only have the nursing case mix groups to worry about. Since Massachusetts won't be including the NTAs or the therapy case mix groups as part of its calculations, and come to think of it, since PDPM nursing case mix groups were pretty much just taken from the RUG-4 nursing rugs, some of us have been seeing these categories since 2010. So if you've been doing this for a while with me, expect to start recognizing things that you've seen before. But if you're a little newer to the MDS game, never fear, because Stacy's going to go top to bottom through those case mix groups with you in just a second with some pointers I think even you vets will appreciate. Now, the state has made it so there won't be any additional MDS assessments required beyond the ones that you are already required to complete for the federal MDS regulatory requirements. In addition to that, what you needed to do for MMQ, you're gonna be able to put that aside, right? So definitely a little bit more of a workload reduction from that side. So let's hit the next slide. So nothing too new here, but let's take a quick review of the timeline requirements for MDS completion to make sure we have it all fresh in our minds, since this is now going to be affecting our payment. So if we take a look at the requirements of when all these assessments need to be signed, we've got a bit of a 14-day pattern that's going on here. All of them either needing signatures 14 days after the ARD or 14 days after the significant change or error was identified. Except our friend, the admission assessment. That's the one that you need to pay attention to, because you can schedule the resident's admission ARD all the way out on day 14. But if you do that, you will have 0 extra days to complete and sign that assessment. An admission assessment with a day 14 ARD needs to have that assessment completed and signed on that ARD. So we want to make sure that we're staying in compliance with all of our OBRA requirements in regards to scheduling, in regards to signatures, because these are going to be items that's going to determine if you're getting paid or not. So Zach, if you can hit the slide. Okay. As far as scheduling out these assessments, we're going to continue to follow the federal scheduling requirements that are outlined in the RAI manual. We'll have OBRA assessments that will need to be completed at least every 3 months or 92 days, with a comprehensive assessment needing to be done at least every year, so 366 days. And it would be your admissions, annual SIG changes, and SIG corrections that would be those comprehensives, basically every OBRA assessment that isn't a quarterly assessment that needs to be done at least once a year. Now, I know I just said that we would be continuing to following those comfortable federal guidelines we've been used to all along, but I do have one little caveat. Under the federal guidelines, if a resident is discharged prior to day 14, their admission assessment isn't required to be completed, right? You can leave it right there. That data is supposed to be saved, but you don't have to complete and submit it, and there really isn't any consequences to that. Well, while it may technically still be true from a compliance standpoint on completing the assessment, you're not going to be able to get paid if you don't have your admission assessments completed. So if you want to be able to bill for a resident of any length of stay, prioritizing the collection of your MDS data upon admission, especially those nursing case mix group criteria, will be more crucial than ever. So to reiterate those MDS assessments and scheduling requirements that we've been building upon, Mass Health will not require any additional MDS assessments beyond what is already federally required. If you follow the RAA guidelines as your North Star, you can't go wrong, except for admission assessments. Make sure you always complete those, because otherwise you're not going to be able to get paid. Another note to keep in mind is that we will have some MDS changes on 10/1 not associated with Mass Health's transition to PDPM, and one of those will be the replacement of Section G with Section GG, which will be needed for the function score calculation of your nursing case mix group. So you definitely want that process on lockdown by the end of the month. And we will have a great webinar up on our website now. Mark and Megan did that back in June. That covers Section GG in a lot of great detail. So you can take the opportunity to take a great deep dive there and get your wheels spinning on how you might want to adjust your facility processes on 10/1, because that data needs to be collected for all those Mass Health residents. Otherwise, you're not going to be able to complete those Section GG function scores and get your case mix groups. So next, we're going to talk about our Medicaid ID numbers. So your patient's Medicaid number, going to make sure it makes its way into A700 on every assessment of every kind. Even if Mass Health isn't the primary payer on the ARD, this number absolutely needs to be there for you to be able to bill in the future. And if it doesn't make its way in there the first time, you have to go back and modify the assessment. So, and for clarification, if a patient is Medicaid pending, but they have a Mass Health ID, because they are in the process of that long-term care conversion, you should still include that Mass Health member ID in the MDS assessment in A700. So basically, every opportunity you can take to get that in there, you want to do so. And since the Medicaid number being in A700 hasn't been a facet of Massachusetts' historic reimbursement model, I know we're going to see some dual eligible skilled residents that come into the facility and won't have their Medicaid number in the admission assessment because the ARD was on a skilled day and it was overlooked as important. But now, since all of you who have decided to join us today got that heads up, I know that doesn't have to be any of you. So just very important to get that Medicaid number in. And next, we have the nursing PDPM groups. So I'm going to pass it off to Stacy, who will take you through some of that in depth.
Perfect. Thank you, Matt. And I really want to emphasize a couple of things that you said earlier. Although Mass Health is not going to change any of the requirements, they did say that they will publish some additional information. So we'll watch out for that and watch out for that. If it comes out, make sure that you read that and understand any additional clarifications that they put out for us. Another thing I really want to emphasize is that admission assessment. I cannot tell you how important that is, because we've been in the habit when someone stays at our facility for less than 14 days, we don't do an admission assessment. And that didn't matter for Medicaid payment, but it will now. So you want to look at these PDPM nursing group components with every admit that comes into your facility to make sure that your MDS is accurate. And that's really our focus, is we want to capture all of the cares that we're providing so that we have an accurate MDS and we're getting paid accurately for the care that we're providing. So I'm going to dive into the nursing component for PDPM. Like Matt said, this is actually the same nursing component that's been involved with the RUGS groups for several years. They've just condensed it and made a few little tweaks, but it's essentially the same thing. So if you were a nurse that has been working with those RUG calculations, you'll understand this. Or if you're an administrator or somebody who's been working, you should be able to start recognizing some of these things and have it make sense to you. So with this nursing component, there are several different things that impact it. It's not, with our RUGs, we got into the habit of really the only thing that we were focusing on was the amount of therapy minutes that we were providing. Over 90% of our RUGs billed were at that therapy level. And so although these questions were still on the MDS, we weren't focusing on them because it really didn't drive payment. So we're going to dive deep into all of these different things. You've got your nursing services, your diagnosis, conditions, behaviors, your cognition, respiratory therapy, your function score, your PHQ 2 through 9. Remember, that's changing October 1 for all item sets. It's going from your PHQ 9 to our PHQ 2 to 9, and then our restorative nursing. The first thing that we're going to do is we're going to calculate your function score. The thing I like to really point out, I usually see a lot of fear in people's eyes when we talk about section GG, especially if you've only been a long-term nurse and haven't really done much with PDPM for your Medicare. There's always a lot of fear when it comes to GG. And I really want to point out that these GG items that you have up on your screen, they are still those 4 late loss ADLs that we've used from section G. You've got your first bullet, which is eating. Your second is toileting. Your next 2, your sit to lying and lying to sitting on the side of the bed, are bed mobility items. And then your last 3 are transfer items. So you still have eating, toileting, bed mobility, and transfer. It's still those late loss ADLs. They're just broken out. 2 of these items come from your self-care category in GG 130, and then the other 5 come from your mobility category. So the total score that you can get is 16. So a resident can score anywhere from 0 to 16 on their function score. And that's really important to note. Remember, our goal is just to document accurately so we can code the MDS accurately. The next thing we're going to look at is we're just going to look at the hierarchical classification system. You simply start at the top and look at the qualifying factors that put the resident into that category. And if they don't have any, you'll just move down to the next group until they do meet the criteria. And then that's where you'll stop. There's no need to go on any further. So you've got extensive services, special care high, special care low, clinically complex, behavioral symptoms and cognitive performance, and reduced physical function. So those are the categories that your residents can qualify into. This is a really awesome tool that QRM has. It's called a Buzz tool. And this just has each of the different nursing components and all of the factors that play into that. So it's just a quick snapshot of everything that goes into this nursing component, which we're going to discuss today. So the very top category there is extensive services. There's only 3 ways that a resident can be placed into this category. It's a tracheostomy, a ventilator or respirator that's invasive, or isolation or quarantine. Those are the only 3 things, and they have to occur while the resident is at your facility, while they're a resident at your facility. The thing you need to remember about this one, if the GG score is a 15 or a 16, so that tells me that my resident is highly independent, they will automatically drop down to the category of clinically complex, which we'll look at that here in just a minute. So I actually saw this happen quite a bit, especially during the height of COVID. There were a lot of residents that met the criteria for isolation per the RA manual. There's 4 criteria listed there. They met the criteria. We coded isolation on the MDS, but then it would only give a clinically complex. And I would have MDS nurses call me and say, what is the matter? We got isolation, but it's only giving us clinically complex. The first thing we look at is that GG score. And if it's that 15 or 16, you're not going to get the credit. So you're doing all of this work to help the resident as they're in isolation. It takes all of that extra care, but you're not getting reimbursed for it. The moral of the story is pay attention to how they're doing functionally. How is their function score? Is it accurate? If it's accurate, it's accurate, and there's nothing that you can do about it. But did we really go and do all of the things that we can as far as the GG? Did we interview the staff? Did we interview the resident? Did we observe in lots of different settings at night and in the morning so that we could figure out what their usual function is? Remember, for GG, it's not their worst and it's not their best, it's what their usual function is. So something to really think about. The next category that we have is your special care high. Now, what I've done is I've broken these out of where this information is coded on the MDS so that it's easier to see where it's coming from. So we're going to talk about the different things that put us into this category. So the first one that we have is in section I. So this is where our active diagnosis go. So you have septicemia, diabetes, but if they have diabetes, they have to have two things that occurred. One, the insulin injections for all 7 days, and insulin order changes on 2 or more days. Then we have quadriplegia with a nursing function score of less than or equal to 11, and COPD and shortness of breath while lying flat. You have to remember that with the PDPM model, it really was designed for our acute Medicare A type residents. So a lot of these categories, our long-term residents aren't going to have these types of things. And so it's really important that we pay attention and we're documenting what's actually going on with the resident. With this category, I would say the opportunity that's missed most often is that COPD and shortness of breath while lying flat. And how do we capture that shortness of breath while lying flat is we can do it a couple of different ways. Sometimes our residents, they'll elevate their head of bed by themselves because they're having difficulty breathing or shortness of breath, but they won't notify any staff. They won't tell staff that that's the reason why they're doing it, but they know if I elevate my bed, that will relieve that. Or they use pillows to prop up their head. But again, don't tell the staff why they're doing that. They just say it's more comfortable for me. So is your staff asking those probing questions? Are your staff asking those probing questions of why is your head elevated? Or why do you have so many pillows underneath your head? Or if the resident complains of it, those are all different things that then we have to go document in the chart so that we can get credit for that activity that is occurring. Then we move on to section J, and in section J, this is where if the resident has a fever and then one or more of the following, and a fever has a very specific definition in the REI manual, so make sure you understand the definition of a fever. So if they have a fever and pneumonia, or fever and vomiting, fever and weight loss, or fever and a feeding tube. Now the feeding tube, it can't just be they have a feeding tube placed, they actually have to be receiving calories through that feeding tube. So it has to be 51% or more of their daily calories, or if they have 26 to 50% of their daily calories and 501 cc's or more of fluid through that feeding tube, it would count. And that's all documented in the MDS. The next one we have is section K, and this is where you have your parenteral or IV feedings. This can occur while not a resident or while a resident. It's a 7-day look back period. So oftentimes with our new admits, they'll have IV fluids in the hospital for hydration or nutrition, and we're able to capture that. This is a lot harder to capture on our long-term residents, but it's something you need to look at. And is it something that you can perform at your facility, or it could be something you've had to send them out and they get it at the hospital. The key factor here is it's a 7-day look back period. The other important thing to note here, and this is one that a lot that Mass Health, I can almost guarantee, is going to be looking at if you code this, is there documentation to support the need for hydration or nutrition? That's what they're going to look for, is that documentation that supports hydration or nutrition. Now I'm going to spend a little bit of time talking about what these PDPM nursing classifications mean. I know a lot of us have seen these, an HBC1, what does that mean? How do I know? So we're going to kind of break this down. So first thing I want to note on here for our special care high, I told you that the function score goes from 0 to 16. However, on here, you can see the highest it goes is 14. And that's because it has that same rule. If they have a 15 or a 16 function score, they automatically will drop down to clinically complex, even if they met all of the other criteria for a special care high. So again, accuracy in our function score is crucial. Now let's look at the third column there. The H, that first letter, tells me that they met the criteria to get into special care high. Now the BC and the DE, that tells me what function score group they classify into, either 6 to 14 or 0 to 5. Now that last character, a 1 or a 2, that's determined by the PHQ-9 score. Now it will transition to the PHQ 2 through 9 score. So if they have a 9 or below, they'll get a 1, and that says that they didn't have depression. If it's a 2, that tells me they had a score of 10 to 99, or 10 or above, but not 99, meaning that they did trigger for depression. One thing I want to point out, I get asked this question a lot. Well, they have the diagnosis of depression. Can't we get the end split of 2? And the answer is no. The actual diagnosis of depression has no bearing on this end split. It's completely dependent on that PHQ 2 through 9. Whoever's doing that PHQ 2 through 9 in your facility, have they had education? Do they know how to appropriately administer that? Do they have strategies in place to make sure that the resident feels comfortable when doing those interviews with whoever is doing it? Okay. Now we'll move on to our special care low, which is our next category. And we're looking at section I again, which is where those active diagnoses are put in here. So cerebral palsy, multiple sclerosis, or Parkinson's disease, those all count here as long as the function score is equal to or less than 11. Okay. And then respiratory failure with oxygen use while a resident. Oftentimes you will see residents who get oxygen at night, but somehow we're not documenting it. So making sure that we're capturing all of those cares that we provide. Then we move on to section K. And with section K, we have, go ahead and advance the slide. With section K, we have our feeding tube while a resident or while not a resident. And this one, we don't have to have the fever. So if they have the fever with the feeding tube, that put us into our special care high. But with just the feeding tube, that will put us into the special care low category. And it's the same criteria where they have to have 51% or more of their daily calories, or 26 to 50%, and the 501 cc's or more of fluid through that feeding tube. This one, we also look at section M. And for section M, it's any of the following wounds, and then you have to have a selected skin treatment. Now, the selected skin treatments are mapped out in the REI manual. It can't just be any treatment. It has to be those specific ones that CMS has said these will count as these selected skin treatments. So if they have a stage 3, a stage 4, or an unstageable due to slough or eschar with 2 or more selected treatments, that will put them there. 2 or more venous or arterial ulcers, and then 1 stage 2 and 1 venous or arterial ulcer will put them into that category as long as they have those selected skin treatments. Then we have our foot infection, diabetic foot ulcer, or other open lesions of the foot with a dressing to the feet. All right, next we move on to section O, and the 2 items that are in here are your radiation while a resident and dialysis while a resident. So if you have they go for outpatient dialysis, that still counts because they're a resident in your facility, or if you have a dialysis den or they have dialysis that's done in their room, that would all count as long as they're still your resident. So we get down to the PDPM nursing classification again. The same theory applies, or the same process applies. The L is what comes from the special care low. And then your BC and your DE, that tells us the function score category that they are in. 2 tells us that they qualified for depression with that PHQ 2 through 9 score. And the 1 tells us they didn't score with the PHQ 2 through 9. Okay. And you'll notice again, there's no 15 or 16. If they meet one of those criteria that we talked about, and they should be special care low, but their function score is a 15 or a 16, they're going to drop down to that clinically complex. Then we've got our clinically complex. So again, we're going to talk about section I, the diagnosis. We have pneumonia, or we have the hemiplegia or hemiparesis. The caveat with the hemiplegia or hemiparesis is they have to have a function score of less than or equal to 11. There is a specific definition in the REI manual of what constitutes hemiplegia. So make sure that you review that. I cannot emphasize how important it is for you to be familiar with the REI manual. Even if you've been an MDS nurse for 100 years, go and review the REI manual, because they put definitions in there. They have some really good examples and scenarios that can help you understand how to accurately code the MDS. Then we move on to section M. So we do have a couple of wounds in here. It's your open lesions or surgical wounds with a selected treatment. You could have burns. It's only those 2nd or 3rd degree. And the selected skin treatments are listed here on the screen, but those are not the same that are used for your special care low. So pay attention to what those specific skin treatments are. Then we have section O, which is chemotherapy, oxygen therapy, IV medications, and transfusions, all while a resident. I can tell you, I have seen multiple times over my career where we miss coding that oxygen therapy because we don't document it. There's an order for it and the staff is placing it, but for some reason we miss that documentation and it doesn't get on the MDS. One thing that I've seen in the time that I've worked with buildings in Massachusetts is, because the MDS didn't drive payment and it was more for those federal compliance, we weren't as vigilant on capturing things on the MDS as maybe we should have been on these over assessments. So really take a look at your processes in your facility. How are we looking at these things? And my soapbox that I always get on is being proactive with your MDS. You know when the ARDs are. So use that look back period to gather information, to ask questions, to do observations. And it should be the whole team involved. It shouldn't just be your MDS nurse gathering this information, but the entire team should be involved, asking those questions, observing, so that when the MDS nurse sits down to do their MDS nurse after that ARD, they can say, I have confidence that I can code this MDS accurately, and I'm not going to have to put dashes, and all of the information, all of the care that we're providing is being coded on the MDS. So if we drop down to the PDPM nursing classification, you see that now we have that 15 and 16 category. So this includes the entire range of the function score, which goes from 0 to 16. Okay, so the C is what tells me it's clinically complex. The A is what tells me they're independent with that 15 to 16 score. Then you have your BC and your DE, just like we did previously for the 6 to 14 range and your 0 to 5 range. And then again, the 1 and the 2 at the end tells us they had the PHQ 2 through 9 score that put them into that depression category, which is the 2, and the 1 tells me they didn't meet that depression category. Remember, a diagnosis of depression does not impact this at all. That's totally based on their PHQ 2 through 9 score. Then we move on to the next category, which is behavioral symptoms and cognitive performance. So you can get into this category one of two ways. You can get in there based on cognition, or you can get in there based on behavioral symptoms. But the first thing you're looking at is that function score. And that's why I put step 1, determine what the function score is first, because that could depend on what categories it can and cannot classify into. So if their function score is less than 11, then they automatically are going to drop down to that very low reduced physical function category. Okay. If it's not less than 11, we're going to move on. And the first thing I always look at is their cognition. So we're going to look at their BIM score. If they didn't have a BIM score done, then you use the resident interview questions for the cognition to determine if they meet that criteria. And those are laid out specifically in the REI manual. It's in chapter 6. That's the step-by-step instructions on how to calculate your PDPM. If they don't qualify for cognition, then you're looking at the behaviors. And that end split is determined by restorative programs now. We're not going to be looking at our PHQ 2 through 9. So let's look at those behaviors that classify us into this category. Go ahead and, yeah, perfect. Okay, so in section E, this is where our behaviors are coded on the MDS. So if they have hallucinations or delusions, anytime during that look back period, you're going to code it, and then it will put them into this category. Or if they had physical behavior symptoms directed towards others, verbal symptoms directed towards others, or other behavior symptoms not directed towards others. And that has to have occurred 4 to 6 days or daily in order for it to trigger into this category. This next slide is just going to show you a snapshot of what that looks like in the MDS. This is section E. This is where all of our behaviors are captured. So what you really want to look at is who is documenting these behaviors? Are they documenting them accurately? Who's coding the MDS? Sometimes it's the social worker who's coding the MDS. Do they understand the definitions? Do they understand all of the places in your EMR or in your documentation where they can find documentation to support the MDS coding? Extremely important. And then understanding the definitions of behavior and not just normalizing these behaviors. So like I said, the final, your final end split, your 1 or your 2, is for behavioral symptoms and cognitive performance, is not based on your depression score anymore. It is now going to be determined by restorative nursing programs. So these restorative nursing programs, if the resident received 15 minutes or more of a program, you're going to code that day on the MDS. But in order for you to get credit to get the end split, they had to have 15 or more minutes a day for 6 or more days of that 7-day look back period. So those restorative programs are listed here on your screen, and those are also directly listed on the MDS as well. So when we look at that PDPM nursing classification, you have your nursing function score of only 11 to 16. So 11 to 16, remember, tells me that they're more independent, right? So if they have behaviors and they require a lot of physical help and that function score is lower, then that tells me that they can't classify into here and they will drop down to that reduced physical function. So your B, the very first character, B, tells me they classified into the behavioral symptoms and cognitive performance category. The AB tells me it's that function score 11 to 16. And then the 2 tells me that they had 2 or more restorative programs on 6 or more of the 7-day look back period. And then the 1 tells me that they didn't have 2, they had 1 or less of those restorative programs. The final category is reduced physical function. And this is any resident who doesn't meet the criteria for any of the upper categories will automatically fall into this category. So there's no specific criteria that they have to meet to get here. This is everybody in your facility. I would venture to guess that most of your residents are probably falling into this category at this point, because like I said, we haven't been super vigilant with capturing documentation of those other things that we were doing because it really didn't drive payment. So this is something that you really want to look at. Those residents that are falling into the reduced physical function, is there something else that we're providing or something else that we're doing that could actually bring them up into one of those other categories? And if so, why don't we have the documentation? And what do we need to do to get that documentation to support our MDS coding? And then again, that PDPM nursing classification, it has your full range of 0 to 16, because this has to encompass every resident in your facility has to be able to classify into this if they meet no other criteria. So the P is what tells me it's that reduced physical function. The A is what tells me that they're highly independent, right? They have that function score of 15 to 16. And then you got your BC and your DE. And then remember, the 2 and the 1 are determined by that restorative nursing program. Okay, we do have an in-depth description of the nursing component that's available on our website. It's a pre-recorded webinar that you can go and access. It does go into a little bit more detail, but if you just need to hear this over and over again, it is there. You can go and look at it, and it really provides, it gets you thinking in different ways than you have before in regards to your long-term residents. Like Matt said, we've been using this PDPM system since 2000. Since
2010. Yeah,
2010.
They moved the drug score with fiscal year 2011.
So you've been using this component.
I had to look it up though.
forever. Yes, I'm glad you did. Came to my rescue, Matt. Okay, so that's the nursing component. So now Matt's going to talk to us about the payment periods. This is something that is unique to Mass Health. It is something that they are rolling out effective October 1. So let's hear all about it, Matt.
All right, thanks so much for going through those case mix groups for us, Stacy. But now, like Stacy said, it's time to talk payment periods. So this is where I'm going to need everyone to buckle up, because this is going to be the challenging piece for even those of you who are very familiar with working in other states' case mix models, because Massachusetts is fairly unique in their structure. So Mass Health will adjust the individual resident care levels for 3-month payment periods based off of what is already their regular assessment schedule. The trick is that everyone is on their very own schedule for their 3-month payment period, because their payment quarter can start on any month of the calendar year, and it isn't even correlated with the rest of the facility patients' quarterly periods. So, if you've worked in other states and have snapshots, you're like, oh yeah, quarterly payments. Massachusetts is different. Everyone gets their own quarters. So now that I've made everyone nervous, let's break it down and make it simple. So first thing, back one. Not there yet. So first thing is your current facility residents have already had what their payment quarters are going to be set from their previous assessments ARD. So they don't spend any time worrying about trying to have the resident payment period start on a certain month, because those dates have already been picked out for you, as Mass Health has been collecting that data from MDS assessments since this past June to determine when the residents' usual assessment timeframes are. So a payment quarter will be 3 calendar months set at a given level based off of a PDPM nursing case mix groups. So 3 calendar months, not 92 days. It's going to be, January, February, March. It's going to be March, April, May. In most cases, that quarter's level of care will be determined by the regularly scheduled assessment completed prior to the first of the month of the new quarter. So you'll probably need to put something in place to track individual resident payment quarters, since they'll all be different from one another. So, like I said, buckle up. And to make it extra interesting, Mass Health has also said that an ARD determining the level of care could be after the start of a payment quarter. And while there are 3-month windows throughout the year with less than 92 days in them that could lead to that happening, Mass Health hasn't released exactly what the methodology for the determination of a regularly scheduled assessment is. So we'll have to see what more we find out about that, the model, and how that's going to be implemented. But even just with quarters having, or 3 calendar months in a row having less than 92 days, you're going to end up in that scenario where sometimes that ARD isn't going to be in those months, and Mass Health is going to continue on with that regularly scheduled quarterly, determining that next payment period. All right, so we got some examples for you. So this is what it's going to look like. In our scenario here, we have a resident admitting on July 13th. We set their admission date for July 18th. That admission assessment, it's going to determine that initial payment rate all the way up to the end of July. And then the resident's payment quarter is then going to begin on August 1st, and it's going to be first payment month on August, second payment month in September, third payment month in October. And that next quarterly will be due on 10/18. So what's going to happen is your first payment quarter is going to be based off of that admission assessment. And then when your next regularly scheduled quarterly is going to be due, it's going to come due before that current payment quarter ends, and then that level of care, or your PDPM nursing case mix group category, will be what pays starting on 11/1. So that 10/18 quarterly is going to determine that 11/1 payment level for that next resident quarter, which is going to take care of November, December, and January. We'll go through one more time because I know this took a minute for me to get my head around it. So resident admits in July. They have an admission assessment on the 18th. That admission assessment is going to pay for that period up to that first of the month. That first of the month is then going to be the first resident payment quarter. You'll get paid for 3 calendar months, not a day count. The months of the calendar year is what's going to be set. You're going to follow your federal RA guidelines for the assessment scheduling. That next assessment is going to be due on 10/18. So when we do complete that quarterly assessment in October, that payment rate will then be effective on 11/1 for 3 calendar months, taking us all the way to January. And that process would then repeat itself. So let's make it a little more difficult. Zach, can you hit me on the
Why not? Why not? Let's add a little bit more into
why
it.
not? Why not? So now we all got it. I'm going to go through and throw a little wrench in. Now, remember at the beginning of the presentation, I talked about how the SIG change is going to be a bigger piece of this reimbursement model. Well, we have arrived. So the next piece is that the SIG change creates an exception for the fixed 3-month payment period that we have a really hard time modifying, right? That payment period is fixed, but here comes the SIG change. And when it gets completed, that payment level of care is now going to be effective on the ARD, and then it's going to continue at that payment rate to the end of the month. And that's going to reset the payment quarter to start with that first of the month and then go another 3 months. So now we did a great job of tracking this resident's payments quarters. We know which 3 months of the year and when the assessments are going to be due and determine those payment rates. And now we did a SIG change and their whole calendar switches. So this is why it's very important to keep track of what's going on, but we definitely have some tips and tricks in there to help you guys manage. So let's go step by step through this example. So, nope. Yep, that one. Yep. So same resident, right? Admits on July 13th. We do that admission on July 18th. We set that resident payment quarter from that admission assessment. And then that payment quarter was supposed to end at the end of October on that 3rd payment month. But in the middle of the 2nd month, we had an ARD on September 11th. And what happened on that SIG change is that reset the payment quarter to be on 10/1. So that SIG change is going to be effective throughout the rest of the month of September. And then a new payment quarter, instead of beginning on November, is going to begin on October 1st and take you through the 3 months to the end of the year. So let's break down how that payment change happened in the middle. So admission assessment is going to take that first piece of the initial month that doesn't count into that resident payment quarter. Then we're moving into that resident payment quarter, and you're going to have the August paid. And then we get through a little bit of September, and September 1st through the 10th are going to be set at that resident payment quarter. But then we have that SIG change exception, and then on that next date, it's going to take it from the ARD all the way to the end of the month, and you're going to have a split bill. So we'll talk more about the billing, but you're going to submit two claims for that month with the different HIPS codes, and you're going to have half of the days billed with the admission assessment, and then you're going to have the back half of September billed with the SIG change ARDs, patient level care. Then we're changing the resident payment quarter to now start on October 1st, which is going to then go October, November, December. And then whatever that usual quarterly would be due, in this case, December 12th, that is then going to determine the next payment quarter for January, February, March. So we got those fixed blocks that we can interrupt with the sig change. All right, Zach, can we hit the next one? Very good. So now only you can prevent forest fires and also ensure that you are billing Mass Health with the right level of care. So it's important to keep track of where your residents are in their payment quarter. But if you get it mixed up or confused, you'll be able to look in Mass Health Provider Online Service Center to be able to determine what their active care level is for the payment quarter. And I think this is probably something that's going to need to happen pretty often as you are starting with this new reimbursement model, especially with not all of the clarifications of the determination of what is the usual quarterly. You're going to want to make sure that the assessment that you have submitted, you see it in the Provider Online Service Center, you know that is the active level of care, and you are getting that reimbursed at that level, and you're submitting your claims appropriately. And even though the sig change did create an exception in the fixed payment quarter structure that we have going on here, I want to reiterate that it is the exception, as you can do all the quarterly and annual assessments in the world, and it won't reset the payment quarters, right? You could do 92 quarterlies throughout the whole quarter, and you're still going to end up on that same 3-month fixed period without a sig change assessment resetting those payment periods. All right. Next. Okay. So here we have a breakdown of the different assessment types, how and when they start impacting payment, and when they end impacting payment. So let's talk about these exceptions to our assessment, setting this fixed and unmovable 3-month care level. If you'll take a look at the quarterly and annual assessments for a moment, you'll see the payment for that level of care will start on the first of the month of the beginning of the next resident payment quarter. The first exception I want you to take a look at is the one we already discussed, the sig change. As we reviewed in the last example, a sig change will start a new payment care level on its ARD, then reset the payment quarter to begin on the first of the month with using that care level for that upcoming payment quarter's rate. So you can basically think of it as a sig change page for 3 months and some change, and unless that quarter is interrupted by a discharge or another sig change. Okay, so if we understand the sig change, the next two are going to be a breeze because basically they're the same thing. A significant correction of a comprehensive or a significant correction of quarterly will function exactly like the sig change, paying for 3 months and some change by resetting the payment quarter. Last exception isn't too different, and we saw it in both examples we used. An admission assessment will determine an active care level from the resident's first full payment quarter and any days prior to the beginning of that quarter from their admission date. So again, looking at that 3 months and some change of payment going on there. So here are some assessments that we wanted to give full clarification that they will not impact payment on the next slide. So your Medicare PPS discharge, your entry tracking record, and your death in facility are not going to have any impact in payment. So next, we're gonna go to so now that we have a fairly good understanding on how the payment periods are determined for billing, and we know what we should be paid, let's talk a little bit more about how we'll actually be billing claims for those payment periods. So when we submit our claims, we will always be billing for the entire month's days under one claim at just one care level, unless we have a significant change or a correction completed. And even when we submit the claims for the exceptions, you will be needing to submit 2 claims for separate care levels you are billing. So It will still only be one care level per claim that you submit. Very important. You want to get paid, one care level per claim. Now, those MDS submission timelines we discussed for each assessment type are going to come in play with your billing, as any MDS assessments that are submitted late or missing will have the associated claims suspended for 3 weeks. And I know I love getting my paycheck on time, so it's going to be very, very important to keep up with those requirements. So on the next slide, you're going to see we break down the HIPS codes a little bit, and you're going to be submitting the full PDPM HIPS codes, right? You got your PTOT, your speech, your nursing, your NTA groups, and all of those letters are there. Only one of them matters, and it's going to be that third letter. It's going to be your nursing case mix group, because that is the sole letter that is representative of your nursing case mix group, and also representative of the payment rate for your nursing services component. So on the next slide, you'll see we have if you're used to Med-A PPS billing, I'm sure you've seen this. It's the nursing case mix groups with the associated HIPS letters. So basically the higher acute, the lower in the alphabet, and it just goes on down. And then, so if we hit the next slide, so one great thing about this transition is that the rate calculation is going to simplify for everyone. For example, these are the state's only 25 rates for the nursing per diem component for the 2024 rate. You might notice that the case mix group rates aren't what you're seeing in the PPS case mix group rates, right? So that ES3 of 395, well, what it is Massachusetts took the fiscal year 2022 PPS PDPM case mix groups weights. So if you look at these numbers and you're like, hey, that does not match, you're not going crazy. The case mix groups weights for your PDPM will not match PPS. So 2 numbers, they're going to be pretty close, but again, don't put too much into it if you think they might be off a little bit. Just know it's supposed to be that way.
Matt, one thing I do want to point out with these rates is it's not an A through Y. If you notice, you have A, B, C, D, and then it skips to F. We sorted them by your highest paying to your lowest paying. So Y is your lowest paying and A is your highest paying, but it doesn't necessarily go in order. It's based off of the acuity. So you'll notice like your HBC2 and your HBC1, there's quite a difference in the pay between those two, even though they're both a special care high with a function score of BC, but that 1 and 2 end split makes a huge difference. So don't just think, oh, I have an E, that's a higher paying. That may be a lower paying, or that is a lower paying than your F. So just something to pay attention to.
Yeah. Thank you, Stacy. And Zach, you hit us for the payment impact. So this is going to be a breakdown of what we're looking for on kind of anticipation of billing. So Mass Health will now require the use of the Revenue Code 22 and the corresponding HIPS codes on all of your claims. The service units billed for Revenue Code 22 should match the Room and Board Code 100 exactly, right? You should bill as many nursing service days as you do patient days that you're billing for. And for clarification, you should not include services reported for medical or non-medical leave under 185 or 183. You're going to always have Revenue Code 22, the amount of service units, be identical to the Room and Board Code 100, or you may have some issues getting your claims paid. And then, so next slide, we'll kind of take a quick recap of billing before I give you back to Stacy, but so remember, 1 HIPS code submitted per claim. Only the HIPS for the level of care can be submitted on that claim. And you can find that in your POSC if you're not entirely sure where that calculation came to on what is the usual quarterly that they selected. The new payment quarter is going to be effective the first month after the level of care effective date. If a sig change or correction is completed, again, you're going to split the month into 2 separate claims because, again, you're only limited to 1 HIPS code per claim. If a resident's on a medical leave of absence when an assessment is due, the MDS assessment may be completed up to 14 days after they return. And also, there's lots of opportunities for getting denied on technical matters. So putting into place a triple check that includes that your revenue code is with your HIPS code and the service units match, and that your level of care is what's in POSC, that you've submitted your assessment. Because again, if you don't submit your assessment, you're going to get a 3-week suspension on your claim getting paid out. So I think triple check here is going to be vital to not have delays in payments or issues getting reimbursed. But I will hand you over to Stacy to talk a little bit more about the SIG change assessment.
Wonderful. Thanks, Matt. I do want to point out that the state has said that they will auto-generate a weekly report of your submissions that have gone through and had no issues, and then one that has errors. So you should have a process as part of that triple check process to be proactive, making sure, that they have their Medicaid number and A700, making sure, like Matt said, all of your revenue codes, your dates are correct, but then making sure that that MDS is correct as well. And then checking that report weekly. And if there are errors, it'll tell you what the errors are. You go and fix those so that you can get paid instead of delaying that payment. So like Matt said, what we're going to talk about now is the significant change. I know when he brought up the different payment periods and how your significant change will reset that resident quarter, and it will start paying as of the ARD. I could just see lots of people starting to strategize and think of all these things. Oh, well, we'll just do a significant change so that we can capture that. The significant change in status assessment, every single one that you do will be audited by Mass Health or whoever they hire or to do those audits. So it's very important that we understand what the definition of a significant change. So on the next slide, this is directly out of the RAI manual. I did that on purpose because knowing that these are going to be audited, we don't want to alter the definitions. We don't want to change the meaning. We want to make sure that we understand what is actually written in the RAI manual and that we have a good understanding of when a significant change is required and when one is not. I would also suggest that when you and your team determine that a significant change in status is required, that you document that in the medical chart. This is why we decided X, Y, and Z occurred. This is why we're doing a significant change in status. And then that way it's easier for auditors. It's easier for you to kind of jog your memory and remind you of why you determined that one is required. So a significant change is a major decline or improvement in a resident status that will, 1, not normally resolve itself without intervention by staff or by implementing standard disease-related clinical interventions. The decline is not considered self-limiting. 2, it impacts more than one area of the resident's health status. And 3, requires interdisciplinary review and or revision of the care plan. So if the resident just gets IV fluids, you give them the IV fluids and they bounce back and they're fine and there was no change in their care plan, there was no change in, they were able to bounce right back, a significant change in status is probably not appropriate at that time. But again, if you document the reasons and it meets the criteria, then you're okay to do it. So it's something that you guys are going to have to pay more attention to than you normally would have, because it is going to be audited and it does impact our payment. There are some specific instances which are listed on the next slide, which the REI manual singles out and says, okay, these are the things, go ahead and move to the next slide. These are the, back right there, yep. These are the things that do require significant change. So an improvement or decline in the resident's condition from their baseline that is not expected to return to baseline within those 2 weeks, okay? And there are lists of examples. They're not all-inclusive lists, but there are examples of declines or improvements in the REI manual. So go and look at those. You've got your different ADL scores or different things like that that are listed in there, that if those happen, those change, that's going to impact a significant change decision. If the resident enrolls in hospice, or they change hospice providers, or they revoke hospice, each of those instances require a significant change in status assessment. Moving on to the next slide, this is also directly from the REI manual. When a resident's status changes and it is not clear whether the resident meets the significant change in status guidelines, the nursing home may take up to 14 days to determine whether the criteria are met. Okay, there's that 14-day number again. So you have time to decide as a team and say, hey, you know, we had to give IV fluids for hydration. Let's look at this resident. Let's see if this is going to be more of like your like a permanent change or something that's going to alter and stay with the resident. Let's see if it resolves. So you have 14 days to look at that as a team and determine, nope, they meet the criteria. We're going to go ahead and do a significant change. Again, make sure you document that in the medical record so that you show that you had that conversation. This is the information that you had. This is the decision you made as a team. And then, like Matt already mentioned, but I think it's worth mentioning 100 more times, the significant change in status MDS will change your payment as of that ARD. So in that month for Mass Health, you're going to have 2 separate claims, one with whatever they were in that resident quarter and one with what their HIPS code changed to when you did that significant change. Documentation, documentation, documentation. We know that these are going to be audited. So make sure you understand the criteria and you're documenting that in your medical record. Now, Matt's going to talk to us about some of the audits that Mass Health said that they will be doing.
All right, thanks, Stacy. Now it's time to talk about everyone's favorite topic, audits. All right. Now, I know that these reimbursement audits aren't anyone's favorite pastime, but they are going to come around twice every year, and there's nothing we can do to change that. But here's the deal. These audits should not be something that you need to stress out about. If we're documenting on our residents the way we're supposed to, and we're only coding what we have supportive documentation for. These audits are going to be conducted randomly on site at your facility. So just making sure that we're keeping you on your toes. So on the next slide, we talk a little bit about what that will look like. But seriously, these are manageable. If we're getting the things we need to be done, and are only coding what we're supposed to code, this shouldn't be a giant burden. As you would like to expect, the dollar sig change assessments and higher CMI weight case mix groups will be targeted for audit. The sig changes will actually have 100% audit rate in addition to the claims with the behavior add-ons. When the audits are conducted, the assessments will be pulled from the prior 3 months from when they are auditing.
And Matt, I just want to put another plug in here. This is why it's important that we're proactive. We know when our ARDs are, so let's get out there and let's do our observations. Let's talk to the staff, talk to the residents, and make sure that that documentation is in place so that you don't have to put yourself in a hard position knowing that they're receiving this care, but there's no documentation. Do I code it? Do I not code it? You can't code it if you don't have the supporting documentation. So be proactive in getting that supporting documentation so that when you're coding, you know you've got it. And then when the auditors come in, you'll happily hand them the documentation because you know that you have it.
Thanks, Stacy. And so let's talk about what are they going to be looking for? Well, they're going to be looking at the PDPM nursing case mix groups reimbursement dependent items because that we don't have supportive documentation because the state doesn't want to pay us for care they don't think we provide it. So we need to make sure we are putting extra effort in to show our work and have clear and substantive supportive documentation for all the MDS section items that contribute to that PDPM nursing case mix group calculation. So on the next slide, and in addition to those PDPM reimbursement criteria, we've now got to pay extra attention where compliant with our entire MDS completion process and the requirements as falling out of CMS compliance can now jeopardize having your claims paid out, where the MDS process prior to this did not. So, I mean, definitely need to have a much more focused view on tightening up these processes. So if MDS has taken a back seat as a priority to MMQ completion for your facilities, this is now the perfect time to ensure those processes are in place that's going to show your work and make your coding accurate. And then one last item of note is, on this slide is, that any supportive documentation can only be changed by the author. So if you need to make a correction to the supportive documentation that you have, the person who wrote the original supportive documentation is the one that's going to need to change it. And if I haven't sparked you into action and tightening up these processes yet, if you're in the bottom half of facilities for error rates, you're going to end up with a whole nother round of audits to go through. So definitely going to be what I would suggest is a priority for everyone in this coming months. So next slide. So the way that they will determine the count of errors is any errors that result in an inappropriate payment. So for example, completing a sig change assessment that does not meet the RAI's manual's requirements that Stacy previously lined out, and one is opened up, well, you're likely going to get that denied because that's an error in payment. So that's going to be an error against you. And any issues that are found that don't impact payment won't affect your error rate as far as having to do another round of audits, but you still could end up having to do corrective action plans and a Department of Health referral. So again, it's just time to button up all those little MDS compliance items. And since we can leave the MMQ process behind, that should be open everyone up with some resources to dedicate to that project.
So in the next couple slides, I'm just going to talk about the documentation that we want to review to code the MDS accuracy, but also the documentation that your auditors are going to look at to see if you have the documentation to support it. So they're going to be looking at things like your behavior logs and your care plans, your physician notes and diagnosis, pharmacy recommendation, MARS and TARS, your skin logs, restorative documentation, therapy documentation, really anything that is in that medical record, they're going to be looking at. So we want to make sure that we have reviewed all of the documentation when we're coding those MDSs. We want to make sure that we've looked at absolutely everything that is documented and making sure that we're coding that MDS accurately. On the next slide, it gives you a few other items that you want to look at: your pain and your fall risk and bowel and bladder assessments, your fall history, dietitian assessments and progress notes, your dental documentation, social service documentation, mental health specialist documentation. There's so much documentation that goes into this, and you want to be prepared for when those auditors come in, knowing that they're going to look at absolutely everything that's in the record. So if there are things that are contradicting each other, you want to make sure that you have a process that you've gone in and you've reviewed it and you've rectified it and are able to speak to why it is the way it is. Now, Matt, you keep saying MMQs are going away. MMQs are going away. They are, but there's a few reminders that we really want to point out. What are those?
Oh, yes. Just some last minute MMQ reminders to leave you with as we shut the door on that model. So no dates of service after September will require a licensed nursing summary to be completed. But don't start the party just on 10/1, as that might be too soon, and forget that all of the licensed nursing summaries required for the dates of service prior to 10/1 still need to be completed for your past billing. So if we want to get paid for September, it's still an MMQ month. But once we get that wrapped up, we move fully onto MDS land, and you're going to have all that time you spent with MMQs to get those processes tight and kind of fully move forward and embrace this new model.
Yeah, and I think it's important to note that it's dates of service prior to October 1. So if that requires documentation elsewhere, you've got to make sure that you're following those same processes you've always followed for MMQ for the dates of service prior to 10/1. Just know that the rates effective 10/1 will not include MMQ. It'll be solely based on those OBRA assessments. So we've got your MMQ turnarounds, and they'll still be due in September. Tell us about that, Matt.
Yep. So all the September billing, all of those items, it's going to continue on just as it was. So if a Mass Health member converts to Mass Health on or before 9/30, the MMQ data will need to be submitted for those payment purposes. So just because we're moving into MDS on 10/1 to follow a PDPM case mix model doesn't mean we don't have to do our homework for our September billing. But like I said, let's get our homework done and then move forward and embrace this new model. And if you guys need any support, of course, we are definitely here to help you through that. So Zach, if you can take us to our last slide of things to consider. Right, so let's talk about, how is the GG information going to be gathered? Who and where are those GG items going to be documented? Who's going to be determining what's usual performance? How are you going to track those different payment quarters, right? And remember, for once you submit an assessment, that will show up what your active level is in your POSC. So double check that, especially as we're starting this model and there's still not all of the kind of algorithm on how that usual quarterly is determined. Check that before you bill. Make that as part of your triple check process. Do you understand the nursing component for PDPM? It's vital that you know not only what those what categories fall into, but what items of the MDS contribute to that, so you know what to code, you know what to have supportive documentation in place for, you know how to qualify, how not to qualify. How will you ensure that information is accurate in the MDS, right? Time to button that up after we finish our MMQ homework. And then who has access to the POSC system? Can they find what they need? Are they part of triple check? Who will be reviewing those weekly reports? Does your entire IDT team need to understand the basics of MDS? Do they know what their roles are going to be? And again, we've been doing MDSs for a long time, but I understand that sometimes those things can take a back seat when you have something else you also need to be compliant for that is reimbursement dependent. And then does your staff understand the timeframes of the resident interviews for the MDS? Because if you're not compliant with when you were doing those items, that risks your payment levels, that risks a denial, a downgrade in reimbursement. So
and I think, Matt, it's so important that not to get hung up on all of the unknowns. Like Mark had mentioned in the introduction, there's a lot of things that are still unclear, and several of us are still seeking that clarification from the state, but focus on the things you do know. You do know that it's going to be based off of OBRA assessments. You do know that it's going to be the nursing PDPM component. So do you understand those things? You do know that there's going to be resident quarters. So making sure that you have a good process in place to manage those resident quarters, know when they are, make sure that assignments are made to people as far as who's going to pull those weekly reports in the POSC system, and making sure that as an administrator, as a leader of your building, knowing how important this is, because most of our facilities were Medicaid based, right? Most of our patients are Medicaid payers. And so this is our bread and butter. This is our bottom line. So as an administrator, I would be super vigilant in creating processes and saying, okay, this is how we're going to manage this. This is who's going to get this. And you can't leave it just up to your MDS nurse or somebody who was an MMQ nurse now, who is now going to convert to an MDS. You can't leave it up to them. It has to be the entire team that's looking at this process, that's having those communications. And then every single month before you bill, making sure that you have the documentation to support what you coded, making sure you know what you're going to bill, making sure that all of those ducks are in a row so that you have confidence when you bill, you're going to get paid and you're not going to have to pay that money back. All right.
All right. So I think, Amy, I think I'll pass it over to you. I know we've got a lot of questions, but I know we've run pretty far over, so we can collect all those and make sure that we get that information back to you. But Amy, can you kind of give the details on that?
Absolutely. So, well, first of all, thank you, Matt and Stacy. Wonderful job as always. Also so happy to see that our participants, I think pretty much the majority, hung on to this point. So that's just amazing, and we really appreciate you being here and tuning in today. So as Matt mentioned, we received a good number of questions. So we want to make sure that we address those and we help you as much as possible. So Matt and Stacy will go through those, answer them thoroughly with what we know, and what we're waiting to find out. And we'll release that. You will receive an email notification when that's ready. But again, within 24 hours, the recording will be on our website. You'll also receive a link for that. And then we'll just publish the Q&As on that page as soon as those are completed. Of course, like Matt mentioned, if you guys have questions on any of this content, you can also navigate to the Medicaid rate tool. We do have an inquiry form there, and so you can submit questions with very quick response time. So that's another resource to you as well. But thank you again for attending, and we hope you have a great afternoon. Bye-bye.